Hello everyone, good evening. Welcome to class. So please let me know if I am audible and visible and we can go ahead. Okay, thank you. So today's session, I will be doing the previous year's questions in ophthalmology, the ones that have been asked in the past, like 2 years or so. Some of the questions are a little bit tricky, so I just wanted to discuss them. I hope the presentation is clear to everybody. Is the presentation clear to everyone? Okay, so let me start with the questions. A 30-year-old female complains of diminution of vision on the right halves of both the eyes, and the visual field defect is given to us. What is the possible site of the lesion? So left optic tract, right optic tract, left optic tract, right occipital cortex, right optic nerve, or optic chiasma. What should be the answer to this question? What should be the answer to this question? Okay, let me know, please. Correct. The answer is A. The answer is A, obviously the left optic tract. So what is the diagnosis from this image? The diagnosis from this image is, this is a homonymous hemianopia, right? What is the field defect that we see here? This is a homonymous hemianopia. Now, why are we calling this as a homonymous hemianopia? Because, see, this is the field of the right side and this is the field of the left side. This is the nasal part of the left eye, temporal part of the left eye, nasal part of right eye, temporal part of the right eye. So the nasal part of the left eye and the temporal part of the right eye are affected. So the nasal field of the left eye and the temporal field of the right eye, these are affected. So this is called as a homonymous hemianopia. Now here we had only left optic tract in the option. That's why the question was easy. Now suppose we have both right and left optic tract in the option. Now, if we have both left and right optic tract in the option, then the question is going to become slightly more complicated. Why? Because then we know that it's the optic tract, but we will have to choose between right optic tract and left optic tract, right? So for this, we need to understand whether we should call this as a right homonymous hemianopia or a left homonymous hemianopia. So will you look at this picture and tell me, do we call this as a right homonymous hemianopia or should we call this as a left homonymous hemianopia? Chalo, tell me which is it? Is it a right homonymous hemianopia or should we call this as a left homonymous hemianopia? Should we call this as right homonymous hemianopia? Correct. This is to be called as a right homonymous hemianopia. Because see, first of all, you need to understand that this is the field of the right eye and this is the field of the left eye. Right? So the right and left are according to your own right hand and left hand, and this represents a right homonymous hemianopia because the nasal part of the left eye and the temporal part of the right eye are both on your right hand side. So see, the nasal part of the left eye and the temporal part of the right eye, both of them are on your right hand side. So this is a right homonymous hemianopia, and if it is the right homonymous hemianopia, then the site of lesion is going to be the left optic tract. Okay, now suppose this picture had been opposite. Suppose this picture had been opposite. That is, suppose it had been like this. Agar aisa hota na, if this is right eye, this is left eye. Suppose it had been like this. Then we would have called this as a left homonymous hemianopia. Because see, now the field defect is on the left hand side. So then we would have called this as a left homonymous hemianopia, and the site of lesion would have been the right optic. Okay, so this is what is actually important to be learned from this question. In this question, they have given only left optic tract, so it's actually easy. But if they give both left optic tract and right optic tract, then how do you differentiate? Then we have to understand that if this blackening or the field defect is on your right hand side, then that's called as a right homonymous hemianopia. Site of lesion will be left optic tract. But if it is like this, then it's a left homonymous hemianopia. Site of lesion is the right optic tract. Okay? Chalo, let's go to the next question. This is the visual field defect of a patient. What is the site of the lesion? Now, right occipital lobe, left occipital lobe, right optic tract or optic chiasma. What is the answer here? Now, here we have right-left combinations given. So, now this is the visual field defect. What is the site of the lesion? So see, this is nasal, this is temporal, this is nasal, this is temporal. See, what is this? This is a homonymous hemianopia because the nasal part of the left and the temporal part of the right eye are affected, but it is a homonymous hemianopia with where the central part is clear. Look at the central part, it is clear. So this is a homonymous hemianopia with what is called as macular or central sparing. So this is a homonymous hemianopia with macular or central sparing. Once again, see, it is on the right hand side. So it's a right-sided homonymous hemianopia with macular or central sparing. And we know that this central sparing is seen in the occipital lobe if there is a lesion in the occipital lobe. But it's a right homonymous hemianopia with macular sparing. So site of lesion is the left occipital lobe. So this is where the concept of right and left again comes into play. So this is a right homonymous hemianopia with central or macular sparing. So that's why the site of the lesion is the left occipital lobe. Right. Now quickly let us revise what is the artery that is affected here. Will anybody be able to tell me what is the artery that is affected? It is an infarct in the territory of which artery? It is an infarct in the territory of which artery? Correct. It is a PCA territory infarct. Very good. So it is a PCA territory infarct. Okay. Chalo. Let's go to the next question. Okay, just before we go to the next question, will you be able to tell me what is this defect? So far we were talking about only homonymous hemianopia. हमने पहले ये वाला देखा homonymous hemianopia. Then we learned homonymous hemianopia with central sparing. What is this? This is the right eye. This is the left eye. This is nasal, temporal, nasal, temporal. Yes. So here see the blackening is on the temporal parts of both the eyes. So it's on the temporal part of both the eyes. So what are we going to call this? It's the temporal part of both the eyes. So this is called as a bitemporal hemianopia. Correct. And the site of the lesion therefore is your optic chiasm. So here thankfully there is no question of right or left because it's a midline structure. Bitemporal hemianopia site of lesion is the optic chiasm. Right? Let's go to the next question. Yeah. Can you tell me what is this? What is this defect and where is the site of the lesion? Once again, let's name it as right and left. What is this? This is also a homonymous hemianopia, but it's partial, right? It is a homonymous hemianopia, but it's partial. Only superior homonymous hemianopia. So this correctly is called as pie in the sky. So pie in the sky matlab site of lesion will be, yes, it is the Meyers's loop or the temporal lobe. Very good. The site of the lesion is the temporal lobe or the Meyers's loop, but that is not why I put up this question actually. You will tell me whether this is right-sided pie in the sky or left-sided pie in the sky. What is this? Is it a right-sided pie in the sky or a left-sided pie in the sky? What is this? Is it a right-sided pie in the sky or left-sided pie in the sky? Correct. This is a right-sided pie in the sky again because see the blackening is on your right-hand side. So therefore the site of the lesion will be the left temporal lobe or the left-sided Mayer's lobe. ठीक है, the same concept that we applied for homonymous hemianopia वो same ही है यहाँ भी. We are applying the same thing here also. So this is a right-sided pie in the sky. So site of the lesion is your left-sided temporal lobe or your left-sided Mayer's lobe. The same goes for this picture also. This is just a complementary to this, or I should say it's the counterpart of the previous picture. So इसको क्या बोलेंगे? This is called as pie on the floor. This is called as pie on the floor. And what is the site of the lesion? The site of the lesion, correct, it is the parietal lobe or the Baum's lobe. The site of the lesion is the parietal lobe or the Baum's lobe. Once again, we have to call this as right-sided pie on the floor. Therefore, the site of the lesion is the left parietal lobe or the left Baum's lobe. So, this is a right-sided pie on the floor. So, site of the lesion is the left-sided parietal lobe or the left-sided Baum's lobe. ठीक है, so यहाँ से the one that we need to learn is actually the right and the left. ये right and left if we learn, then this question we will not get wrong. Okay, chalo, let's go to the next question. A patient presented with vision loss and on radiological examination, there was an aneurysm causing damage to the optic chiasma. Which of the following may be a possible cause? Which of the following may be a possible cause? So, anterior communicating artery, middle cerebral artery, anterior choroidal artery, anterior cerebral artery. Yeah, so see, we can understand that there is a bitemporal hemianopia which has been caused by compression of the optic chiasma, right? So now, what are the common lesions that cause this bitemporal hemianopia and compress the optic chiasma? So see, may these two we already know, that is pituitary adenoma and craniopharyngioma, ये हम normally पढ़ते हैं. The other two that you need to know are anterior communicating artery aneurysm and cavernous sinus thrombosis. These are also conditions which cause optic chiasma involvement. Okay, so whenever there is a compression of the optic chiasma, you end up with a bitemporal hemianopia. The common lesions that we see are pituitary adenoma, craniopharyngioma, and anterior communicating artery aneurysm, and also cavernous sinus thrombosis. So the answer here is this: anterior communicating artery aneurysm can damage the optic chiasma. So in the last, say, 2 years, these are the questions on visual fields that have been asked in different exams. Let's go to the next section. A patient presenting with leukocoria underwent denucleation and histopath shows this. This is called as a Flixner-Wintersteiner rosette. Now, what is the diagnosis? Very simple question. Correct. The answer is retinoblastoma. Correct. It is a retinoblastoma. So, the child has presented with leukocoria, that is white pupillary reflex. And as a treatment for this condition, there was a removal of the eyeball with a part of the optic nerve. That's called as enucleation. And on histopath, you see these tumor cells arranged around this central lumen like this, which is called as the rosette pattern, and the most typical pattern that you see here, the Flexner-Wintersteiner rosette, gives us a diagnosis of retinoblastoma. Okay, there was another question from retinoblastoma, that is this: what is the most common route of spread of retinoblastoma? What is the most common route of spread of retinoblastoma? Now, this is actually, according to me, a very confusing question. Direct spread, hematogenous spread, optic nerve invasion, and lymphatic spread. So, which one should we choose here as the answer? Yes, actually both A and C are correct. The most common route of spread of retinoblastoma is a direct spread via the optic nerve. So, direct spread can be either through the sclera or through the optic nerve, both, right? So direct spread can be both through the sclera as well as the optic nerve. Now both of them are common. Optic nerve is probably a little more common than scleral invasion. So direct spread via the sclera and direct spread via the optic nerve, both are seen, but direct spread via the optic nerve is more common. So this is the answer that we should choose probably out of these two, because direct spread can be through the sclera also. The direct spread through the optic nerve is more common, of course, but this is the one that seems to be more correct. However, they should have avoided giving the option number C. But even if this is there, we should choose A as the option. Okay, let's go to the next question. A female with a history of prolonged contact lens use presents with foreign body sensation, and this is the clinical picture that's given to us. Now, what is our possible diagnosis? So, is it a spring catarrh, that is vernal keratoconjunctivitis? Is it trachoma? Is it an acute follicular conjunctivitis, or should we call this as GPC, that is giant papillary conjunctivitis? Correct. This is a giant papillary conjunctivitis. So see these flattish elevations on the upper tarsal conjunctiva. So what is this picture? This is a picture of the everted upper lid. This is a picture of the everted upper lid, and you see these flat topped elevations like this. So these flat topped elevations here, these are called as papillae, and these papillae are very large. So this is called as the giant papillary conjunctivitis. Now, giant papillary conjunctivitis, this is seen in any kind of constant irritation to the conjunctiva, like for example, an ill-fitting contact lens. So, if you have an ill-fitting or prolonged use of contact lens, especially if it is not properly fitted, ill-fitting contact lenses, suppose there are protruding sutures. Suppose there is a surgery which has been done and there are protruding sutures which are constantly irritating the conjunctiva, or as this case says, a patient who is being prolonged use of contact lenses, or somebody who has an ill-fitting contact lens, these conditions, they give rise to this kind of an allergic reaction on the upper tarsal conjunctiva, because every time the patient blinks, the conjunctiva gets rubs on this surface, and it gives rise to this allergic reaction which is called as giant papillary conjunctivitis. Okay? Next question. A patient of POAG has a history of bronchial asthma. Now, which of the following should be prescribed as an anti-glaucoma drug in this patient? So, latanoprost, carboprost, gemiprost, alprostadil. Which is the one that should be used as an anti-glaucoma drug? This was an easy question actually, because see, this is the importance of knowing what are the available drugs in each class. Now, all of us know that prostaglandin analogs are used as an anti-glaucoma drugs. But whenever we learn about any class of drugs, we have to learn what are the available members in that particular group. Because, for example, when I say beta blockers, there are so many beta blockers, but all beta blockers are not available as eye drops. Similarly, all prostaglandins are not available as eye drops. They are not used as eye drops. So, which are the PG analogs used in glaucoma? One is latanoprost, correct. And what are the other two? What are the other two PG analogs which are used? None of these are used. These are not used as anti-glaucoma drugs. So, which are the ones that are used? Apart from latanoprost, can you tell me? Apart from latanoprost, what are the other prostaglandin analogs that are used? We have travoprost and we have bimatoprost. So latanoprost, travoprost and bimatoprost. These are the ones which are used as anti-glaucoma drugs. So the rest of the prostaglandins are not used as anti-glaucoma drugs. So the rest of it is actually not important. The fact that the other three are not available in ophthalmic preparation, that itself tells you that latanoprost is the only one that can be the answer. Okay? Chal, next one. This is a very good question. A patient presents with pain and redness in the right eye, and on examination there are keratic precipitate with cells and flare in the anterior chamber, and her pressure is around 40 millimeters of mercury. Now, which of the anti-glaucoma drugs should not be used in this condition? So, mannitol, beta blockers, carbonic anhydrase inhibitors, PG analogs. So, which of the following should not be used? Correct. The answer is PG analogs. But first of all, let us look at the question and try to understand that what is the diagnosis. See, they have told us that there is pain and redness, there are keratic precipitates, and there are cells and flare. So this gives us a diagnosis of uveitis, because in uveitis you have a painful red eye, you have capies, you have cells and flare. But along with the uveitis, it is not just uveitis. Along with uveitis, you have a pressure of 40 millimeters of mercury. So what is this? It is not just uveitis. It is uveitis with high intraocular pressure. So it is a uveitic glaucoma, which is also called as inflammatory glaucoma. So basically, the question is asking which class of drugs is contraindicated in a uveitic or inflammatory glaucoma. Which class of drugs is contraindicated in a uveitic or an inflammatory glaucoma? Okay. The answer is PG analogs. But actually, you must know that in uveitic glaucoma, we don't give PG analogs. PG analogs must not be given. Second, brimonidine also must not be given. Now, why these two classes, these two drugs are avoided? Because both of them, they increase the inflammation. Both of them are known to increase inflammation, and both of them are associated with an increase in the risk of cystoid macular edema. Now, cystoid macular edema in itself is a complication of uveitis. So, in itself, cystoid macular edema is a complication of uveitis, and these two drugs, they further increase the chance of causing cystoid macular edema. So that's why it is to be avoided in this group. So PG analogs and brimonidine are not to be given in uveitic glaucoma. Also, pilocarpine theoretically should not be given. Why? Because pilocarpine, what does it do? Pilocarpine, it increases the ciliary spasm and it causes miosis. So see, in uveitis, we want to decrease the ciliary spasm and we also want to dilate the pupil. So decreasing the ciliary spasm and dilating the pupil, that is required in uveitis. So pilocarpine anyway is not very commonly used, but theoretically it is also not to be used in uveitic or inflammatory glaucoma. Okay? So PG analogs nahi dena hai, no brimonidine, no pilocarpine. Okay? Sure. Let's go to the next question. An elderly female patient presents with gradually progressive decrease in vision, and this is the clinical picture. What is the diagnosis? Is it hard exudates in diabetic retinopathy? Is it the soft exudates in hypertension? Is it CRVO? Or is it flame-shaped hemorrhages in hypertension? What is this? What are these? Yes, these are actually the hard exudates that are seen in diabetic retinopathy. So see these yellow deposits here. These yellow deposits, these are actually hard exudates. These are the hard exudates. These are the hard exudates, and if you have this kind of hard exudates at the macula, that is called as clinically significant macular edema or CSME. Clinically significant macular edema. CSME. Clinically significant macular edema or CSME. So this is a very important entity, which means that you will have hard exudates or retinal thickening. Hard exudates or retinal thickening within 500 microns of the center of the macula. So here see you have hard exudates or retinal thickening within 500 microns of the center of macula. So this is a very important entity in diabetic retinopathy where you have multiple hard exudates which lead to retinal thickening or retinal edema at the center, that is at the macula. And why this is important is because hard exudates at the macula, they are responsible for decrease in vision. So even if you have say hard exudates, hemorrhages in the periphery, that is not going to disturb the vision that much. But when you have these kind of collection of hard exudates which leads to retinal thickening right at the center of the macula, then that becomes very clinically significant because that leads to decrease in vision. So this is where an important entity in diabetic retinopathy, that is CSME, clinically significant macular edema. Okay, so one more question. A patient with a history of ocular injury while working with chisel and hammer presents to the emergency. Which of the following should not be performed for localization of the intraocular foreign body? So X-ray orbit, CT scan of the orbit, USG B scan or MRI of the orbit. So which is the one that is contraindicated? In this case, which is the investigation that we must not do? Correct. We must not do an MRI of orbit. Common sense question. Why? Because this is a metallic foreign body. So this is a metallic foreign body. So we must not do an MRI of the orbit. We all know that for a metallic foreign body, we must not do MRI. So that is the answer in this. Okay, so this was a quick run through of a few of the previous year's MCQs. Now, tomorrow, I want to remind all of you that we are having this test, that is the All India mock test. Tomorrow, that is the 26th of February at 9 a.m. So this is, I would want all of you to enroll for this test, and the link is available for you to enroll in the description itself. You can enroll for this test, and please do participate in this test. The questions are going to be very predictive of the main exam, and there will be video solutions given to you, and also we will be discussing the questions on our app, that is on our Unacademy special classes tomorrow. So different educators will be discussing their respective subjects. So after you take the test in the morning, an analysis of the questions and the solutions with the explanations will be doing. The video solutions anyway will be provided to you. Along with that, we will be discussing the questions also tomorrow and day after. So this is a very good opportunity for all of you to test yourself before the final exam. It will help you to test your preparation, show you where you stand, and very importantly, it will tell you which are the concepts which are still not clear to you, so that you can read them again and complete your preparation. So do participate in this All India mock test. Enroll now, and tomorrow at 9 a.m. I would request all of you to do take this test. Right? And those of you who are still not a part of our Plus platform, so you can enroll for the Plus subscription. So you can use my code, that is Dr Sudha, for the same, and also you can enroll for the iconic subscription which entitles you to the best of both Unacademy and Prep Ladder, and for that also you can use my code, that is Dr Sudha. And there is something which is a very new announcement, that we are soon coming up with this PG Notes, which is a comprehensive set of notes curated from the live classes of all the educators, and they are going to complement the video lectures for the respective subjects. So these notes are going to be available for students who take a longer subscription with the Unacademy platform. So this is a new announcement from our side, and the most important announcement for today is the All India mock test, that is for tomorrow morning. So do enroll and be a part of this test. Listen to the solutions and the discussions, and I'm sure that this is really going to help you. Right? So thank you very much for being a part of this session, and do download the app if you have not done it already, and join the communities of the educators, and do join my community also. And there I will be putting up the links for the different special classes and YouTube sections that I will be doing. So download the app and do become a part of my community. Thank you very much. See you again in the next class. Bye-bye.